Excellent. All right, so welcome everyone to today's special presentation. As I said in my email, this one is on voluntary assisted dying. The purpose of the presentation is to give you an overview of the legislation that the Queensland Government has passed recently. One of the things that we do want to make really clear on behalf of MND Queensland is that our decision to organise this presentation in no way reflects the organisation's position on the legislation or the options that it creates for people. What we do believe strongly in, though, is client choice. And we think it's really important that when people are making choices, they're making informed choices. So we wanted to make sure that everyone had a clear understanding of what the legislation entails. And Carol, who I will allow to introduce herself in a second, has very kindly offered to share her expertise on the legislation with you so that we can make sure that everyone is coming from the same position in terms of understanding of what the new laws are. So at that point, I will mute myself and hand over to you, Carol.
Thank you, Stacey. Can everyone just, someone can hear me? Everyone can hear me? Stacey? Yeah, okay. So thank you very much. First of all, I'd like to thank MNDAQ for letting me provide this information to you guys today. My name's Carol Hope. I wear a number of hats, but I'm presenting this on behalf of the Care at the End of Life Collaborative, which is a West Northern Region entity, but I have various roles within palliative care particularly. My background is palliative care nursing, including doing some volunteer work for Palliative Care Queensland. So I also wanted to just mention that I'm very, very aware this is an incredibly sensitive topic to anybody within our community. So what I hope to do today is to provide you with the information that is currently available, give you a little bit of background, give you a little bit of background as well about how this is rolled out in Australia, so that you've got a bit of a better understanding of how it's going to work in Queensland, and happy to take any questions as well at the end. If I can answer them, I will. Okay, so I think the first thing is to put this, hang on, let me just move my slides. There we go. First thing is to actually give you an understanding of what voluntary assisted dying is. And I think it's important to say that it is a term that is used interchangeably with euthanasia, with physician assisted dying, with assisted dying. So it all means the same thing. But the voluntary assisted dying, or VAD, which is the acronym, is what Queensland has chosen to go with. And it refers to the assistance provided to a person by a health practitioner to end their life. Now, just to be clear, that's not necessarily about assistance in terms of administering something to end somebody's life. It's about seeking assistance to actually get to that point. And obviously the voluntary part means that there is choice involved from the person that's choosing to opt for voluntary assisted dying. And it is important that they are competent, they have capacity to decide to access that. So what I'll do, we'll see a little bit later on about what the criteria are that are sitting in the legislation at the moment, and then you'll see how all that fits in. So just to give you a bit of an overview of what's happened in Australia, this has been an incredibly busy and dynamic space in Australia for some time. So many of you may have heard about the historical kind of what happened in the Northern Territory, which was back in the 90s when the Northern Territory passed the Rights of the Terminally Ill Act in 1996. It was subsequently overturned by the Australian government within 12 months of becoming legislation. So that's going kind of back into deep history. But obviously what we are, I guess, understanding now is that the community appetite for voluntary assisted dying has definitely changed. And you can see there the states that have some kind of legislation available at the moment. So Victoria was the first to go in 2017, and they're probably the exemplar state for most because they've actually been experiencing this now for over 2 years. The implementation happened in July 2019, and Western Australia implementation started, so it commenced this year. The other states, Tasmania, South Australia and Queensland, we're still in that implementation phase. So we look to places like Victoria. There's probably not enough information or data out of Western Australia just yet, but we do look to Victoria to see what their experience has been and see if we can learn from that. Now, this slide is a bit busy, but I just wanted to kind of make the point here that whilst we have all these different legislations in different states, they are broadly similar, but they do have some nuances and they do have some differences. So I'm not going to go through all that because I know that will bore everybody silly, but it's just to kind of point out that there are some differences, and I will try and point out the major differences as we go through the Queensland legislation. So in terms of what's happening in Queensland, the background, it's been going on for some time, although I suspect for the last 12 months it's probably felt like this has been very high up on the agenda, but it has been around the traps, I guess, for some time. In 2018 to 19, we had a parliamentary inquiry that looked at aged care, end of life and palliative care, and they included voluntary assisted dying in that parliamentary inquiry. And at the end of that, when the report was brought down for that, they separated out voluntary assisted dying from the rest of the recommendations, and they referred it to the Queensland Law Reform Commission, which means that they're the experts, they're the legal experts that then look at all the aspects that need to be looked at, and then they draft the legislation as well. So in May this year, the Queensland Law Reform Commission published their draft legislation, and it was introduced in Parliament in May, which is the important part for consideration by Parliament. And then on the 16th of September, actually it was the 14th to the 16th of September, it was debated in Parliament, and as you guys probably know, it was passed into law on the 16th. So what that means is that the legislation that we're aware of, that we've seen, we're all able to look at and access, is now passed. But we go through a period of implementation, which means that we have to set up all of the processes and all of the information and the training, etc. And that's going to take, from passing the law in September, about 15 months. So there is a hard deadline for the government to implement the voluntary assisted dying legislation from the 1st of January 2023. So we've got a little bit over 12 months left. Now that's very different. That's one of the differences for us and the other states. We're actually going to try and implement this much quicker than any other state has. So mostly they take about 18 months, but South Australia particularly, they haven't actually announced, whilst they've passed the legislation, they actually haven't announced yet when it will be commenced and implemented, because they just don't know how long it's going to take to work all that out. So that's the timeline for us, 1st of January 2023. I guess one of the things that people are most interested in is what are the eligibility criteria for VAD, and remembering that this is the legislation, so there will be a whole load of guidelines and processes and procedures that sit behind the legislation, and that's what that 15 months is all about, making that happen. So, but the eligibility is that the person who applies for VAD has a disease or a condition or an illness that is advanced, it's progressive, and will cause death within 12 months and is causing intolerable suffering. Now, again, this is something different to the rest of the states. We're the only state at the moment with legislation that says that any condition, illness or disease where somebody's expected to die within 12 months. All of the other states are 6 months, expected to die within 6 months, unless you have a neurodegenerative disease, obviously like MND, in which case it's 12 months. The point about intolerable suffering is absolutely a subjective assessment, which will be done, and we'll go on to the process, but will be done by the assessment, the doctors who are actually assessing the person that's making the application. So it's very subjective. There won't be guidelines around what that means. In Queensland, you'll need to be 18 years or older. You will have to have decision-making capacity. So this can't be done when somebody's starting to lose if they start to lose cognitive capacity. It can't be a decision that's made by family members or even the substitute decision maker when it comes to health decisions. This absolutely has to be a decision by the individual whilst they have decision-making capacity. obviously that then leads into it has to be voluntary and without coercion. So, and there are a series of assessments that you go through to make sure that to the best of our assessment, the person is not being coerced in any way. Of course, one of the, I guess, concerns has been around tourism into, and I think they called it, so if you look at places like Switzerland, Dignitas in Switzerland, obviously have a lot of people going to Switzerland to end their life through their voluntary assisted dying program. And there was a lot of concern in Australia that, particularly in the States, that people would move to Queensland or indeed Victoria to start with. So what the legislation allows for is that for a start, people need to be either an Australian citizen or a permanent resident, or they have to have been resident in Australia for a minimum of 3 years prior to the first request that's made. And for Queensland, they have to have been resident in Queensland for a minimum of 12 months prior to that first request. Now, there are exemptions to that. So that they're very high level, and that you have to go through essentially the Chief Health Officer or the Attorney General to get an exemption. And that's all about if you've moved interstate but all your family are here and it's something that you want to be around your family, there is an opportunity to be to have that exemption granted, but we don't quite know the guidelines around that just yet. So that's what the eligibility criteria for voluntary assisted dying will be in Queensland. The process is pretty complicated. Now, this believe it or not, is actually a very simplified process, and I will go through it briefly because I don't want to confuse anybody, but it's designed to be robust. It's designed to have all sorts of safeguards in there, and it's designed to make sure that when the person gets to the end of the application period, that absolutely have given it due consideration and they still want to go through with that request. So there has to be 3 requests made along the way. The first request has to be made to a coordinating doctor. Now, we'll go on to some of the safeguards a bit later on, but not everybody's going to be a coordinated doctor. It has to be somebody who is trained, who has the specific training and license, if you like, within the medical profession to actually have that, to be a coordinating doctor and make these assessments. That coordinating doctor then does the first assessment for eligibility, so looking at those eligibility criteria that we've just been through. Obviously, if somebody's not eligible, then the request is declined immediately. If they go on to, if they are eligible, if that coordinating doctor thinks they're eligible, then they make a referral to a second doctor, which is the consulting doctor. Now, the consulting doctor again has been through all of the training, so it's just somebody different, but they have full understanding of what the legislation and requirements are. So likewise, if that consulting doctor finds that the person is not eligible, then they will have their request declined at that point. If they're eligible, then the person makes a second request for voluntary assisted dying. Remembering they've got to do 3 separate ones. The second request has to be formal, and it has to be in writing. And it has to be signed and witnessed by somebody who is happy to sign to say that they believe that you have cognitive capacity to make this decision. Excuse me. Excuse me, I should have brought a glass of water with me. So once that's been done, you can then, and there can be periods of time between these requests. Then once that's all been signed off, the third request is made, and the person makes what's called an administrating decision. Now, what that means is, because in Queensland you can either self-administer or you can have a practitioner administer. Now, you can only have a practitioner administer if it's not feasible for the person themselves to actually administer that medication. So there is that option if you don't have physical capability to administer the medication, but the preferred, well, I guess it's definitely self-administration, and you can't, if you can self-administer, you can't opt to have a practitioner administer. You actually have to take it self-administer. So that happens at that point. They also have to appoint a contact person. that contact person is then responsible for letting the coordinating doctor know if obviously when the medication has been taken, but also if the person that has already been through this process dies prior to taking the medication, naturally, then that contact person is the person that contacts the coordinating doctor with that information. And that contact person is also shared, the contact is shared with the VAD board, which we'll talk about in a little bit, the review board, and that's really about the safeguards as well. When it comes to prescriptions, so the prescription will be issued and it will be sent to an authorised supplier. What we're thinking at the moment is that we will have a statewide pharmacy for this medication, so that it won't be, and I always use the example of cannabis oil. You know, you have to have a licence to dispense cannabis oil in Queensland, but it can be through a community pharmacy if they have the appropriate licence. But we think that with this one, it will actually be through a central state owned supplier, so it'll be through Queensland Health Pharmacy, we suspect. So, and that's the process, and then it's entirely up to the person that's been through that process as of when they wish to take the medication, and indeed if they wish to take the medication, because what we know from Victoria is that there is definitely a gap between people that go through the process and have the medication and people that actually take it as to end their life. So, you know, sometimes I think that what we're certainly learning is that people possibly feel a little bit more reassured and comfortable knowing that that option is there for them if and when they need it, but they don't always need it and they don't always go through with it. And that's absolutely their choice. There are some really strong recommendations or requirements rather than recommendations around storage of the medication, but I won't go into that today, but just so you've got some reassurance from that point of view. So that's generally the process. As I say, it is a bit of it's quite a convoluted process, but it does make sure that at least there have been various points along the way where conversations have been had and where more thinking can happen. So it does make sure that the decision that's made at the end is absolutely the one that the person is wanting to make. So I wanted to just go through, so I've talked a little bit about safeguards, and there are many of them in the legislation, but these are the ones that I think are really important. That often, I guess these are the ones that came up as well in the debate in Parliament. Really interesting that, you know, some questions that were asked, particularly those who perhaps were voting against voluntary assisted dying. So the inclusions are one of them around conscientious objection. And there is no provision in the legislation in Queensland for organisations to object and to not provide information about voluntary assisted dying. However, there is provision for individual practitioners. So, and as an example, a residential aged care facility organisation can't say we're not going to participate. They're not allowed to do that in Queensland. But the nurses and the doctors that work there, they can say, I don't want to participate. But there are some obligations, which is that you have to be able to, you have to refer somebody on to somebody who is happy to participate. So it's a little bit grey, a bit of a grey area for health professionals, but I think the guidelines that we'll see coming out in the next few months will help to reassure people around that as well. In terms of residential aged care facilities, definitely there's differences between whether somebody is a permanent resident or if somebody is a temporary resident as to how they can be managed in this process. So another safeguard is around training. So anybody that is participating in the voluntary assisted dying process or measure, I guess, program within Queensland, they will have to have mandatory training. So there are eligibility requirements for that. So it can't just be anybody popping their hand up and saying, I'd like to be involved. There are eligibility requirements and they have to go through pretty stringent training, and particularly those that become coordinating doctors. They will have extraordinary training to go through. There is a prohibition on healthcare workers initiating conversations about voluntary assisted dying, which is really interesting. And again, this is one of the differences between all the states about what they allow, what they don't allow. Here in Queensland, only medical practitioners and nurse practitioners can initiate a discussion about VAD, but they must include as part of that discussion all of the end of life options, including palliative care. So you can't just suggest that somebody might want to think about voluntary assisted dying. You have to actually put it in as a suite of options. And any other healthcare worker other than a doctor or a nurse practitioner, who are very high level nurses, we're not allowed to initiate conversation. So somebody can initiate it with us and we can respond, but we can't actually start that conversation. There will be a statewide Navigator service which will provide information and support for people who are seeking VAD. I'm really hoping as a nurse that these are nurses, because I think nurses are very good at navigating people through systems. But I also, that this is essentially where people will be who have some questions or need some information. The Navigator service will provide that, and then they'll make sure that they're coordinating in with the right people, making sure people can actually move through that process that we talked about earlier in a timely way, so that you've got some support and some help there helping you through the process. It's not just about the individual and their family trying to navigate through this very complex process. There will be support through the Navigator service. And the other safeguard, which is worth mentioning, is definitely there will be a VAD review board. So this is a very high level board. They will review every single case. They will make sure that the process has been followed meticulously, and they will randomly audit and monitor what is going on as well. So that's something else, I guess, that was very important to the community. So what's happening now? Since the legislation was passed almost 2 months ago now, what's happened is that we have what's called the Voluntary Assisted Dying Task Force that has been set up within the Queensland Health, within the government, and they are very high level people. So people like chief medical officers, chief executives of hospital and health services. Health Consumers Queensland has representation on there. It's a very high level kind of governance group that's going to make sure that everything is done in a timely way before that implementation date in 2023. Underneath the task force sits 7 subcommittees, and I kind of see them as advisory groups. So as an example, you've got one which is around community and community consultation. So there'll be an advisory group that will advise around how the community want to see this being rolled out. Another one is for Aboriginal and Torres Strait Islander people. So they have making sure that the guidelines are consistent with all the requirements from our First Nations people. And sitting underneath the subcommittees is the Voluntary Assisted Dying Unit, which is a department that's been set up within Queensland Health. It's in the Prevention Division. And they will do all the work. The subcommittees inform the task force around policy, but they also inform the VAD unit around what's going to happen, what's going to come up in those guidelines, etc. So that's where we're up to now. And as I said, 1st of January 2023. So that's all I have to present to you today. I did put these links in here, and obviously I am very happy to share this presentation as well with Stacey if anybody wants to have a copy of it, and also if you want to, particularly for those links there. The Queensland Health website has a whole section devoted to voluntary assisted dying, and it's comprehensive, and I'm hoping that will provide that information as it becomes more and more available from the implementation team. And the QUT End of Life Law Centre is the only end of life law centre in Australia, and they've been very involved in assisting the Law Reform Commission based on research and evidence that they've been doing. So that's it from me. If anybody has any questions, I'm more than happy to answer what I can.
Excellent. Thank you so much for that, Carol. Did you want to stop sharing your screen so we can all come back to the group at a slightly bigger?
Just trying to work out how to do that.
Let me see if I can do it for you. No, it doesn't appear that I can.
Okay.
Oh, there you go. I've done it.
Oh,
so excellent.
awesome.
All right. Well, if everyone could please unmute themselves now, then we can move over to questions.
I've got a couple of questions in regards to the type of people that might be asking for this in terms of lack of ability to actually sign any documents when they're ready to ask for it, and also the significant communication difficulties they might have, may not even be able to communicate by speech.
Yes, that really, really good points. And at the moment, I look towards the Victorian legislation and the Victorian experience and their processes, because I think that obviously there's broad similarities in this. So because we don't know yet what those guidelines may look like, but I suspect that we will absolutely have guidelines around how do we assist people who have difficulty communicating, and also obviously people who have difficulty with using with signatures and what have you. There will be electronic versions, and I think that there certainly will be things put in place and options around how we make sure that the communication is appropriate for the individual. But I don't know what that looks like yet, because we don't have the guidelines yet. But I know that Victoria have experienced that, and they have overcome it, and it's always a challenge, as you can imagine. But they will do everything they can, and that's where I think the statewide Navigator service is going to be really important, because whilst they're navigators, they also will act as advocates. So making sure that, you know, it may mean that they may have to have an additional safeguard with an additional person come in to make sure, maybe from the review board or somewhere like that, to make sure that everything is compliant with the legislation, but it's not insurmountable. It's difficult, but it's not insurmountable. I wish I could be more specific though, but I can't at this stage.
Any other questions?
Karen here. Just a question. What kind of format is this medication? Is it tablet, liquid?
It's liquid. It's the usual one. Yeah, but I think again that's something that one of the subcommittees is pharmacy, and I think that that's the conversations that they'll be having, because again with liquid there'll be some people that they struggle to actually take the medication. So when it comes to health professional assisted, then there may be an option for a different method through parental kind of administration, perhaps. Obviously liquid we could use through a peg tube, something like that. But yeah, that's something that the task force will be working on. But again, if somebody is unable to actually take the medication themselves, then there is the health professional administration option, and I suspect that that's what the parental, so by injection or through a subcutaneous little tube.
Okay, so if they have motor neuron disease and we've had a frontal lobe dementia, will they have the capacity to make that decision? No.
No.
Yeah.
No. So it's absolutely clear that the person has to have capacity to make the decision themselves. And so that is why with the rest of the states, with the criteria in the rest of the states, the criteria are that you have to have incurable disease, but 6 months prognosis unless you have a neurodegenerative disease, in which case it's 12 months. And I think that was probably part of that. It was about understanding that, you know, those with neurodegenerative diseases, obviously that deterioration affects those particularly important functions. But in Queensland, it is the 12 months out for everybody. So, but yeah, I mean, obviously, I understand that, particularly with motor neurone disease, there can be rapid deterioration and there can be very slow deterioration. So I think that they've done what they can in terms of the 12 months.
Mm-hmm.
Yeah.
What if someone?
Sorry.
What if someone starts the process, then halfway through they're incapable of actually continuing the process because they can no longer speak? What then?
If they can't speak, then there will be other things that they might be able to put in place. There will be processes that they can follow. If the person loses capacity along that process in terms of decision-making capacity, then I think it will end they will make them ineligible.
So they've got to do it while they're still capable.
Yes, and I think as well there's got to be a minimum of 9 days between the first request and that third request. So that's the minimum, is 9 days. My sense is, and certainly from Victoria, is to get all of that done in 9 days will be really ambitious. However, I think if something is if the story is compelling, obviously they'll make it happen. But I think the process is probably more likely to take more like 6 to 8 weeks.
And after you've been approved and you get the liquid, how long do you have to actually take that liquid, or can you wait until you decide?
You can wait for as long as you want to. And as I said, many people in Victoria, around about a third of people never take it. So as long as it's that there'll be requirements around storage, things like keeping it has to be in a locked box and up high so children can't, any medication will be the same. But this one obviously is particularly dangerous, but yeah, you can keep hold of it. When the person dies, whether it be through, if they haven't taken the medication, it's that contact person that's then responsible for returning that to pharmacy, to the statewide pharmacy, the authorised pharmacy.
Isn't that a little bit dangerous leaving it at home? Like I was a veterinary surgeon, you had to have a lockbox for anything like that. And you're talking about having a lockbox in a house with access. To me, I think if you weren't going to take it straight away, shouldn't there be a safer place held so it's easy accessible?
Come here.
I completely agree. I think that's one of the, so I should probably point out that I have nothing to do with the, I'm not on the task force or anything like that. But yes, that was certainly, Karen, I think that was certainly one of the things that in the debate, that came up a lot as, you know, how safe is it to have this medication in people's homes? My understanding is there haven't been any incidents in Victoria or Western Australia yet. But you know, my background being a community nurse, palliative care nurse, I've seen some pretty interesting things happen to medications that we leave in homes. So it's definitely a concern, but yeah, that's the process at the moment.
That look nice. What are you doing? Watching a program on voluntary.
Have you experienced anyone actually taking this medicine?
Because I'm based in Queensland, so for me, this is very new. It's new for all of us in Queensland. I've probably had the same experience that you guys have had, which is, you know, you may have watched documentaries on the television, but no, I've never experienced it. And in terms of nobody's asked me this, but in terms of where I sit with this, I'm pretty ambivalent about it. My as a palliative care nurse, I believe that everybody should have a choice in the way that they're cared for as they approach the end of life. And I guess this is another choice.
Once the medicine has been taken, how long before death?
That depends. It depends on a number of factors. It can be minutes, but it can take a few hours. It depends on lots and lots of different things. But generally, it's within a few minutes.
Is there pain involved?
To be honest, my understanding is that it's a pain-free experience. but again, I don't know. The idea of the medication is that it's like an anaesthetic. It puts you to sleep, and then so you're not aware of the fact that the body's shutting down.
Thank you.
I hope I haven't upset anybody or freaked anybody out, but that's just where we're at in Australia and in Queensland.
I'll ask a question if that's all right with everyone, if we've got a bit of a lull in questions from the group. One of the challenges is obviously going to be access within the regions in those particular remote areas. I can't recall if you covered off in your presentation, Carol, about the telehealth side of it. Did you? Is that something you want to talk to now, or have you got any comments about how people in more remote areas might be able to access voluntary assisted dying?
My understanding at the moment is that telehealth won't be part of this process, but again, I know that that's something that has been raised by a number of particularly politicians that represent people in those rural, remote, regional communities. So I suspect that might be something that they will look at in this implementation stage. It's very challenging, obviously, for people that live out in those particularly remote areas. And I guess this is where we probably have to look to WA for their experience, although WA, 95% of them all live within that kind of greater Perth conurbation. So, what we do know with this is that the number of people that are expected to actually move ahead and make an application for voluntary assisted dying is actually quite small. It's not, I think that kind of thought that, everybody's going to want to do this, it is actually quite a small percentage of people. So that's been the experience across the world. And, so you then kind of take that out to the populations in the regions, it won't be many. But the reality is that they need to have equitable access, because that's ethically and morally the right thing to do. They need to have equitable access to whatever anybody else in their state can get. So I think the Navigator service will probably be absolutely key in that. And there will be some targeted trying to get doctors out in those regions to do the training and to participate. Tough one though.
All right. Any other thoughts, comments, questions?
What safeguards are there around the medicine? For instance, does it need to be refrigerated? And can small children accidentally take it if they're around?
So the safeguards are around how it's stored at the moment. There's and again, just in the legislation, it's specific, but just really a sentence around that it will be stored safely, and there will be guidelines around how it can be stored. It will be provided in a locked box. But again, that's something that obviously the community are very concerned about, and it's difficult to monitor. So whilst we tell people, so if it's the same with opioids for people who are maybe receiving community palliative care and they have opioids, so drugs like morphine at home, we obviously recommend that they store them high up, away in a cupboard which not in direct sunlight, but away from any children. And obviously we recommend that you don't tell people that you've got that medication in your home, but we can't actually control that. So whilst there are safeguards in place, the monitoring of it is really up to the individual.
Thank you.
Any other? Oh, Jane, did you want to ask a question?
Yes, I can't understand why it's going to take 15 months to be brought enacted.
So whilst the legislation's been passed,
Yes.
that there's no processes and procedures that have been that sit behind it and putting all those safeguards in place. Preparing making sure all the training is being completed by those that are participating, preparing every health facility, whether it be and care facility as well, to make sure that they understand what their responsibilities are, and make sure they've got their procedures and processes in place. And as I said at the beginning, Queensland, we're doing it quicker than any other state. We think South Australia is looking at a 2.5-year implementation.
Oh my God.
Yeah, everybody else has taken about 18 months, and but none of that work could start until the legislation had been passed. So whilst we've been talking about it for a long time,
Yes.
that work couldn't actually start until September. And so they are working very, very hard to do it. And, you know, the Premier and the Deputy Premier are incredibly firm that it will be the 1st of January 2023, that we will not be extending that. So there is a lot of there's a lot of preparation work that needs to happen. It is a huge change for anybody that works in healthcare.
Could be too late for many of us.
Yeah, and I think that's the tragedy, isn't it, of this kind of thing, that
Yes.
It's always
Appalling.
Yeah.
Appalling. Yeah. Okay.
Did anyone else want to make comment or ask any questions before we wrap up?
Yes, I have a question, Stacey, if that's all right.
Go for it.
Hi, Carol.
Hey, Jason, how you going?
How you doing? Good, good. Look, I just have a question around, obviously we're fielding more and more calls as this has been brought to everyone's attention in regards to voluntary assisted dying. Particularly when even family members come to us and say, the person with MND that's in their family has decided, they've made the decision, this is the way they want to go. Is, given what you've said before, which was wonderful, around you're a palliative care nurse and you believe in choice, is that a good place to start if, like, families want to get together and really try and understand what the process is, and particularly around what it looks like, where it's going to happen, all that sort of thing? Is that a good place to start?
With sending them to palliative care services? I think, to be honest, probably the best place to start at the moment would be the website, Queensland Health website. And I know that's not ideal, because I obviously keep an eye on it myself, and it's not. Then these government websites are not easy to navigate. However, that's where all the information is at the moment. My concern about sending people to talk to palliative care is that my experience at the moment within the palliative care sector is that we're pretty divided over this issue. So it depends on who you go to and who you speak to. The medical directors group in palliative care in Queensland are very clear that it's not, that voluntary assisted dying is very separate from palliative care. I think, you have proponents of voluntary assisted dying within the palliative care sector as well. So I think we probably need to sort ourselves out a little bit first before we are unleashed upon the public, and part of that is not having enough information at this point. We're really in this no man's land at the moment. We've got what the legislation says, which is really the bare bones. But we don't know what the meat is that sits behind it, and we don't know when it's coming either. So, but my advice would be to get people to talk to at the moment, to go to the health website, the Queensland Health website, and when those navigators become live, when we start employing navigators, which is probably likely to be towards the end of next year, they will be an amazing source of information for people and support.
Okay, thank you, Carol.
Carol, is there any learnings from the Victoria experience around disagreements within the family units? So obviously it's the person themselves that makes the voluntary assisted dying decision, but when you're part of a family unit, then there will be opinions that will be factored in from other members of those families. So had there been any issues caused by differences of opinion in that respect?
So there's been a few studies around voluntary assisted dying, but the data that's being collected in Victoria is really quite sparse. So we're not getting down to that nuance level. There's been the odd kind of qualitative, which is where they interview people and then write it up as a research paper. But in terms of those experiences, that's not publicly available, as in, because it's just not, that information is not being collected. We also are not we're not getting information from Victoria either around bereavement outcomes for family members following death through voluntary assisted dying, because I think that's an important one as well, just to understand, for me, not necessarily how we actually care for those family members afterwards is really important, and how we support them beforehand is also important. So those kind of things, honestly, Stacey, we've had very little data come out, and that's one of the learnings actually for Queensland, is that we need to be more proactive in understanding what people's experiences actually are and being able to then make changes or what have you around what those experiences have been.
Okay. And what about the things like the aged care facilities, particularly those religious-based ones? Has there been any initial reaction to the fact that that conscientious objection cannot apply to a facility or an organisation as a whole?
Yeah, there's been obviously the aged care, the faith-based, particularly aged care facilities that would have a an objection based on faith, have been very vocal. Unfortunately, that ship has sailed now. That was, that there were amendments that were recommended to the legislation during that debate. There were actually 61, I think, amendments put forward by people, by MPs, and each one of them was rejected. Every single one of them was rejected, which is actually quite extraordinary for a piece of legislation in Queensland. But they were, but that's that I think that was certainly one of them, was around, organisations should be able to have the right to decline to participate. And it will be interesting to see over the next 15 months. I was in during the inquiry, the Parliamentary Inquiry, which was way back in 2018-19. I followed my representation in front of the inquiry, followed a panel of faith-based providers of aged care. And one of those aged care providers at the time, bearing in mind this is 2 or 3 years ago, actually said that they would leave Queensland if they weren't able to object. And,
wow.
So I don't think that'd be happening. I don't think that I think that's a big call to make, because you have a responsibility to the people that you care for at the moment. It has created a lot of obviously distress within those organisations. But that's what the legislation says.
Yeah. Now, Jane, I can't tell if you put your hand up again or if that's from before. Did you have another question you wanted to ask?
Yes, I've actually spoken to my family. They're totally supportive, respect my wishes. So they're very well prepared when I depart on this journey. And I think that's a really good idea.
Absolutely, Jane. I think, we have heard, these are all pretty much anecdotal stories, but, we have heard stories where people have kept it from their family.
No.
That's been, I think that's a really big choice to make. There are obviously people have their reasons. So, I think absolutely done the right thing by involving the families in conversations and helping them to understand why you make the choices that you do.
Oh, absolutely. Yes.
I have a question. It's very hard for someone to actually take one's life. It's very hard. Now, normally under, I assume, normal circumstances, they tell their partner to say, listen, when I get to a certain condition, I no longer wish to be here. But the problem is there any legislation or something for someone, a partner, to actually go ahead and assist? Because once they get to that condition, they're probably no longer able to communicate what they really want.
Yeah, unfortunately, no. Michael, the family members and partners, friends can be in the room when somebody takes the medication, but the only options at the moment are for self-administration or health professional. So the difficulty comes in with that cognitive capacity, because you still have to have cognitive capacity when you take the medication.
What about a written agreement and probably taking the person to the hospital?
That would be done then through the health professional. To be honest, I don't know about how that would pan out at the moment. That's certainly probably a question for maybe the legal experts. But my understanding is that would be, so they'd have to make the decision to have a health professional administration when they're making that decision after the third request.
Okay.
Yeah. There are definitely, sorry.
No, go for it.
I was just going to say there are definitely gaps, obviously. Whilst the legislation is all-encompassing in some ways, for example, the 12 months rather than 6 months, there are definitely circumstances where people will be excluded from accessing that.
And I was just going to add to that, I think it's also worth bearing in mind that this doesn't replace existing end-of-life measures. So things like an advanced health directive does allow somebody an opportunity to record their wishes ahead of time as well. So obviously from a palliative care perspective, then withdrawing life-sustaining measures is also a decision that somebody can make, which is obviously for some less confronting than a proactive measure to end life as well.
And that legislation doesn't change. And actually one thing that I probably should say is that this does not, so voluntary assisted dying is not an either or choice with palliative care at all. And my hope was certainly that regardless of what choice you make in terms of voluntary assisted dying, that anybody that needs palliative care should be able to access palliative care all the way through until that moment of death, however that happens, whether it happens through voluntary assisted dying, through natural causes, through withdrawing life-sustaining measures. Palliative care is really important and should be accessible and available to everybody. And I know, again, we did actually have I did attend a seminar at a conference recently from a group in Victoria. And one of the things that they found in the beginning was that when people actually were frightened to go to palliative care services because they felt they might be judged because they'd taken this choice to have the medication in the home and had been through the bad process. And that breaks my heart to think that people wouldn't access palliative care services, because, you know, the voluntary assisted dying, whilst it's a huge process, it's a moment in time, and it's the way that somebody ends that moment of death. But what leads up to that, and all of the supports and all of the symptom management and quality of life that hopefully palliative care can offer should still be on offer. So regardless of whether this is a choice that people make, they should still be able to access palliative care services as normal.
Absolutely, and I think that goes some way to the point that Jason was leading to earlier around having a referral to palliative care should not be not happen because somebody is considering this as an option, because it is really important that people do know what is available to them. That comes back to what we said around the whole purpose of this is around ensuring informed choice. But in order to make an informed choice, it's important not to just know about voluntary assisted dying, but also about the alternatives. And palliative care services are obviously a very important alternative option that people can explore.
Absolutely, and it's also we should be able to coexist together.
Yes. Yeah.
You know, as I said, it's that you know, if you end up in a hospital, for example, or a palliative care unit, and you choose there at that point that you would like to take the medication, there should be no restrictions on that being able to happen. It may be, so whilst your palliative care doctor may choose not to be a coordinating practitioner or coordinating doctor, that's fine. But you know, it's another choice rather than a completely separate choice. So, you know, I think that again, this is why it's such a difficult subject, particularly for health service providers. And when we think about palliative care, you know, and a lot of the palliative care units across Australia, particularly, are faith-based organisations. So St Vincent's in Brisbane, the hospices are all independent, so they don't have that issue. But it's you know, the large palliative care units in big private hospitals, the Wesley. So there's a lot for these organisations to work through. But I know that regardless of anybody's individual choice, I haven't yet spoken to a colleague of mine in any of the health professions in palliative care who have not all said that this needs to be, palliative care shouldn't change. It shouldn't change anything in terms of what we can provide people. If anything, we should be able to do more to make sure that everybody has access. One of my concerns actually, Stacey, would be that, as you mentioned about the rural and regional areas, at the moment they have very little access to palliative care in those regions, and I'd hate to think that voluntary assisted dying choices were made because those services weren't available to them. So, you know, at the same time, I think it works both ways, but yeah, please don't ever think that you can't access the usual palliative care services or community services, regardless of what choice you make.
Yeah. Okay, I'm conscious of time. Sandy, did you want to say something?
No, I just really I appreciate the candidness of the conversation, and again, there's committees happening across the state at the moment trying to work out each process that they would have within each LAC, I would imagine, so local area within government. So there's a lot of conversations that are currently happening that I'm aware of. So thank you, Carol.
Yeah.
Thank you.
Excellent. Any last comments before we wrap up?
I have one. On your document that you showed earlier, you had 3 different stages that you have to be assessed, the person. Is that a local doctor or is it a government controlled assessor? And are they, second part of the question is, are they all the same person or are they 3 separate people?
So they have to be, they have to have gone through training. So they can, it could be your local GP. If your GP has decided to participate and has been through the training and has a license to be a coordinating doctor, then absolutely it could be that. Otherwise, your GP would refer you on to somebody who did have that license and that training. In terms of I'm trying to think the number of doctors, so you don't have to have 3 different doctors, you have to have a minimum of 2. So what would happen is the first one is your first request is your coordinating doctor. They send you to a second separate doctor who is the consulting doctor, and then you go back to your coordinating doctor for your 3rd request. So it's actually only 2. One of the issues actually in Victoria is that there wasn't a publicly available list of, and I only learned this recently actually at a conference that we did, or a forum that we did recently, but there isn't a publicly available list in Victoria of doctors who are trained and participating in the voluntary assisted dying program, which seems extraordinary to me. But I think Queensland, we will be rectifying that. I think that's because that's something that has been recognised as a real deficit in Victoria. So I think the responsibility, if you go to a doctor, even if your doctor has a conscientious objection or whatever, they have to, by law, refer you to somebody who can help you. So they can't just say, no, I don't want to be involved. In Victoria, they can. In Victoria, they can say, I don't want to have the conversation, and they can walk away. and you then have to go and find somebody. But in Queensland, we have to put you in touch with somebody who can help you.
Thank you.
Okay. All right. Well, I think on that point we will wrap up. So thanks again, Carol, for a really thorough presentation, and thanks all of you for some great questions. It's been a really great engagement and discussion. So I think it's resulted in lots of information being out there and shared. This session being recorded means that obviously other people can see in the future and hear some of the discussions that we've had. So really appreciate all of your time on this. And obviously if you think of any other questions after we've wrapped up, then you should all have my email address. You know how to contact me, or you can pick up the phone if that works better. And if I can't answer the questions or my team can't answer the questions, then I'm sure Carol's always been very generous with her time, so I'm sure she'll be able to help us out. Okay?
Yeah.
All right. Well,